Okay, hi everybody. My name is David Dillon, and I'm going to be talking about the Ebola epidemic that took place beginning in 2014 in West Africa. So, Ebola was first recognized in 1976, during which time two outbreaks occurred near simultaneously in the Democratic Republic of Congo and another in Sudan. In the Congo, there was a case fatality rate of 88%, while the case fatality rate in Sudan was only 53%. These were relatively small outbreaks where only a few hundred people were infected. During these outbreaks, protocols were created by international organizations to stop future outbreaks as soon as possible. Since that time, they have been used successfully to stop approximately 20 outbreaks of the virus in humans. There are 5 different strains of virus in the Ebola virus genus: Ebola virus, or EBOV, Sudan virus, Bundibugyo virus, Typhorest virus, and Reston virus, all of which cause symptoms in humans with the exception of the Reston species. Ebola has 4 recognized subtypes that are named after the geographic area they were discovered in. So these consist of Zaire, Sudan, Ivory Coast, and Reston. Zaire is the most virulent, with a case fatality rate averaging about 80%, while the other 2 infectious strains to humans average right around 50%. Ebola Zaire is a negative strand RNA virus. Symptoms of the Ebola virus begin with feelings of fatigue, fever, muscle pain, and headache. These milder symptoms are followed by vomiting, diarrhea, hemorrhagic diathesis, which leads to external and internal bleeding. It's these hemorrhages that often result in shock and death of the individual. The incubation period ranges from 2 to 21 days, though symptoms usually begin between 8 and 10 days. In the early stages of infection, Ebola can be difficult to distinguish from many other common infectious diseases in Central Africa. Human-human cases are transmitted through body fluids such as blood, saliva, sweat, semen, etc. A person becomes contagious when symptoms first appear. Viral loads are extremely high in the bodies of individuals who have died from Ebola, so transmission is easy during processing of the body post-mortem. Cases are diagnosed by testing blood of a suspected case using real-time reverse transcription polymerase chain reaction assays, though I'll talk about a couple different options that are available later. So, the uniqueness of this outbreak. The first cases were reported to the WHO March 23rd of 2014 from a rural area in southeastern Guinea near the borders of Sierra Leone and Liberia. Due to Guinea's lack of surveillance and infrastructure, an outbreak had been festering there for months. This quickly spread to urban areas and to the surrounding countries. This outbreak is unique because it's by far the largest outbreak of Ebola ever recorded, and it was the largest emergency response by the CDC in the history of the organization. From mid-2014 to early 2016, approximately 4,000 CDC staff members participated in the response effort in West Africa. So the trigger point and responses. The trigger point, like I mentioned, was that first report of cases March 23rd. And because Ebola poses such a serious threat to public health, while the epidemic began earlier than the CDC or the WHO knew about, phylogenetic analysis of the strains points to a single transmission from a natural reservoir that started the epidemic. In this case, it was traced back to a 2-year-old child that contracted the virus and died in December of 2013. The introduction of the virus to Sierra Leone can be traced back to just 12 individuals who attended a funeral in Guinea around this time. While the natural reservoir of Ebola is not precisely known, bats are suspected to be the most likely. Often fruit bats near outbreaks test positive for the Ebola virus genomic sequences, and in this epidemic, either the hammer-headed fruit bat or the little collared bat are most likely to have caused that initial transmission to the child. Surveillance in this area of the continent is difficult for a variety of reasons. Many of the outbreaks begin in rural areas that may not recognize the disease for what it is or are unable to quickly report a case. Infrastructure is a consistent issue in Guinea, Sierra Leone, and Liberia. Relatively low numbers of healthcare workers, weak organization of health services, and high private costs for healthcare are characteristic of this area. While external funds from international organizations in the context of programs such as the Millennial Development Goals have been useful in reducing the incidence of HIV, malaria, TB, etc. Little of this money has gone directly into building the country's infrastructure. This contributes to weak surveillance, and one of the reasons the outbreak could occur for months before the CDC was notified. And as of August 8th of 2014, the outbreak was officially declared an epidemic by the WHO. So, case definition and laboratory methods. A person under investigation of Ebola must have symptoms consistent with Ebola, such as fever, muscle pain, vomiting, hemorrhage, etc., and have an epidemiological risk factor within the last 21 days before the onset of symptoms. And a laboratory confirmed case is the diagnostic procedure for Ebola. Laboratory tests to diagnose the disease vary depending on the timing of the disease. If a person is in the first few days of symptoms, antigen capture enzyme-linked immunosorbent assays, or ELISA, testing is used. IgM ELISA, PCR, and virus isolation can all be used in this time. After recovery, IgM and IgG antibodies are used in diagnostics. In deceased patients, there are options for immunohistochemistry testing, PCR, and virus isolation, though it may take up to 3 days after the onset of symptoms for the virus to reach detectable levels in an individual. At the beginning of the outbreak, confirmed diagnosis was performed by the transportation of venipuncture blood to laboratories that had access to real-time PCR. However, this can result in delays in diagnosis and quarantine procedures. After the start of the epidemic, researchers developed and field-tested a RE-EBOV antigen rapid kit test. This test is a dipstick immunoassay designed to test blood samples, both fingerstick and venipuncture, as well as plasma samples. The test doesn't need any additional instrumentation and can be employed by healthcare workers after very little training. The only limitation is that it needs to be kept at 4 degrees Celsius, so a cold storage chain is needed for transport, something that may be relatively difficult in many rural areas in Central and West Africa. During February of 2015, this kit was field tested in Sierra Leone and evaluated for its efficacy. Results of the test were interpreted by 2 healthcare workers and any disputes resolved by a 3rd. Using this method, the test was found to have 100% sensitivity and 92% specificity. While this isn't exactly perfect, it's useful to employ in areas that don't have access to real-time PCR, or areas where it would take a long time to transport blood samples of suspected infected individuals. So, the main populations at risk in this epidemic were the citizens and residents of Guinea, Sierra Leone, and Liberia, particularly those that lived in crowded metropolitan areas such as Monrovia. Though there were cases reported in the United States, Nigeria, Senegal, Mali, and Spain, the total number of cases were 2, 20, 1, 9, and 1 respectively, though infections in these countries didn't nearly reach the magnitude as in the 3 main affected that you can see. The majority of the population in these areas rely on public transportation, which brings thousands of people into contact with one another daily. If a person is presenting symptoms and are contagious, they can transmit the virus by sweating on other people or exchanging fluids. These high levels of interpersonal contact facilitated the spread of the virus. And you can see here on the slide the total number of deaths in each of the country, the total cases, suspected, probable, and confirmed, as well as laboratory confirmed cases. Then in the bottom right here, you can see some of the descriptive statistics and odds ratios associated with different demographics. In this case, I elected to show you age, so you can see how being a healthy individual, 15 to 44, provides a protective factor for the disease. But you can see in the bottom right-hand corner that elderly population is really high at risk of dying from the illness. And here you can see the incidence rates. So it's starting in the beginning of March when it was first recognized by the CDC and WHO, and relatively low numbers until you hit August when it was officially declared an epidemic, and the numbers just spike after that. In all three countries, they reached their peak between September and November, with Liberia peaking the earliest, then Guinea, and then Sierra Leone, which had the highest number of cases total. So control methods, long and short term, and treatments provided. So control at the district level ministries of health for the three most severely impacted countries, coordinated with a multitude of international organizations, such as Red Cross, Save the Children, WHO, and many others. National call centers set up and received information from the districts on suspected infections and deaths in their area. However, as mentioned before, infrastructure issues limited the effectiveness of responses to this information. For example, the Calhoun district in Sierra Leone had a population of approximately 400,000 individuals, but only 3 ambulances in the entire district to transport people who were suspected of having Ebola. The 4 main non-pharmaceutical methods established by the WHO for preventing the spread of Ebola include 1. Transmission precautions for healthcare workers, 2. Sanitary burial, 3. Isolation of infectious Ebola patients, and 4. Contact tracing with follow-up and quarantine. I'll talk about a couple of these in a little bit greater detail. So, for the general population, the recommendations included practicing careful hygiene. For example, washing hands with warm soapy water or an alcohol-based hand sanitizer. Avoiding contacts with materials that have come into contact with other person's bodily fluids, such as clothes, bedding, needles, etc. Avoiding traditional burial practices that involve directly touching the body, instead following the steps to perform a hygienic burial to minimize the risk of contamination from the deceased individual as much as possible. Be careful to avoid bats and other non-human primates that may act as natural reservoirs for the disease. This is especially important in areas that have high levels of bushmeat trade. Finally, for women in particular, avoiding the semen of a man who has tested positive for Ebola in the past until it's completely cleared of symptoms. This is particularly important as the timing of the clearance varies significantly between individuals. Some men are able to completely clear the virus in 3 months, while others have tested positive for the virus up to 9 months following the initial onset of symptoms. So a really long time between when a person recovers and starts to feel better and resumes their normal life. The virus can stay active in semen for months after that. Healthcare workers whose chances of being exposed to Ebola is significantly higher have stricter guidelines to follow. Most importantly is proper use of PPE or personal protective equipment. This equipment consists of, but is not limited to, gloves, surgical gown, eye protection, boots, respiratory protection, and tape to secure different parts of the PPE. Though healthcare workers must be careful not to tape anything directly to their skin, as the removal of tape can cause microabrasions in the skin that can result in infection. The international community provided thousands of beds to help reduce the spread of disease. In Sierra Leone, for example, almost 3,000 beds were donated by government and non-governmental organizations. While it's difficult to estimate the impact of these beds, using mathematical models, it was estimated that between 48,300 and 84,500 infections were averted as a direct result of the introduction of these beds. During the outbreak, there were no vaccines available, so individuals were treated as their symptoms presented. 3 main treatments greatly increased the chance of an individual surviving an infection with the Ebola virus. The first of these is providing an intravenous drip and balancing an individual's electrolytes. The second is maintaining oxygen status and blood pressure. And finally, it's important to treat any secondary infections or diseases a person acquires simultaneously as the Ebola infection. People who do contract Ebola develop antibodies to the disease that last at least 10 years and perhaps even longer. It's not currently known if immunity lasts for life or if an individual is immune to multiple strains from one infection. So, the accuracy and efficacy of public health responses to Ebola. The CDC acknowledges that a faster, more robust response would have controlled the epidemic quicker. Despite becoming aware of the outbreak in early March, significant concerns were not raised by the WHO until late June. Though up until that moment there was no indication that this outbreak would be significantly larger than the ones that occur every couple years in this region. This was further compounded when, in May, epidemiological indicators suggested that the outbreak was nearing its end in Guinea. The Ghanaian Minister of Health then announced that the outbreak was essentially under control. By the end of the outbreak, it became apparent that all three countries that the epidemic impacted most severely significantly downplayed the number of early cases in the course of the epidemic. For instance, there were rumors of large numbers of Ebola deaths in Monrovia in March of 2014. But at the end of April, the government only reported one case in the entire county. In June, however, a very different epidemiological picture began to emerge, with the reported numbers of infected individuals jumping sharply into the hundreds. While no one was prepared for an outbreak of this magnitude, considering, as mentioned prior, that the previous outbreaks were much smaller, the Secretariat of the WHO was accused of failing to see the writing on the wall and listening to people on the ground. Further, senior officials within the WHO delayed invoking the International Health Regulations, or IHR, of 2005 because they thought it would be viewed as a hostile act or overstepping their bounds. Individuals inside the organization would later admit that the WHO could have responded faster to the outbreak, and that some of the criticism leveled at the organization was appropriate. While there were individual mistakes made in the course of the outbreak, it did point to other, more structural issues within the WHO, specifically their capacity to successfully address an epidemic like the one seen in 2014. For example, in the 12 months prior to the epidemic, the WHO emergency response capacity staff was reduced from 90 to only 36. This was in response to a 51% reduction in spending by member states. Further compounding this issue was a simultaneous response by the IO to other humanitarian crises in Syria, South Sudan, and the Central African Republic. And the Ebola outbreak placed greater demands on the organization. It placed demands on the organization more than 10 times greater than ever experienced in its almost 70-year history. Okay, so long-term consequences. This outbreak resulted in the Global Health Security Agency, or GHSA, committing to help countries improve testing and response times. The U.S. government has committed to implementing the GHSA in 30 countries worldwide and has established new offices in Guinea, Liberia, and Sierra Leone specifically to oversee and provide direct assistance. In response to the outbreak, the University of Sierra Leone, the Ministry of Health and Sanitation, and the United States CDC are currently working on a vaccine trial in Sierra Leone. This initiative is dubbed STRIVE, which stands for the Sierra Leone Trial to Introduce a Vaccine Against Ebola. It is a combined Phase 2 and Phase 3 clinical trial designed to assess the safety and efficacy of the RVSV-ZBOV candidate Ebola vaccine. This is currently taking place in 5 districts in Sierra Leone and is a massive rollout effort enlisting almost 9,000 healthcare workers. Participation is completely voluntary by individuals, and those who are pregnant, breastfeeding, or have compromised immune systems are excluded from participation. The study design itself is an unblinded, individually randomized trials. Placebos were not used. Instead, the 2 study populations are immediate vaccination and deferred vaccination. The vaccine itself is a recombinant vesicular stomatitis virus. So the vesicular stomatitis virus was weakened by removing one of its genes, into the space a gene from Ebola was inserted. Previous studies in numerous other countries show that the vaccine may help prevent people from getting Ebola, but the extent of the protection is unknown. Side effects from the vaccine are mild and usually disappear within 1 to 2 days after administration. The countries at risk now have the ability to respond much faster to potential outbreaks than before the 2014 epidemic. For example, 13 reported cases in March of 2016 led to an emergency response coordinating 5 command centers, 50 healthcare facilities, the use of rapid testing, and the vaccination of almost 1,800 at-risk individuals. In conclusion, the 2014-16 Ebola epidemic was the worst ever recorded since the discovery of the virus more than 40 years ago. Despite high levels of casualties, the governments of the 3 most impacted countries, Sierra Leone, Guinea, and Liberia, with the help of various actors and international organizations, were able to stop the epidemic from spreading farther than it might have. As shown, steps are now being taken to ensure that an epidemic of this magnitude does not happen again. While it's unlikely that the virus will be eradicated in the near future, with new safeguards, outbreaks will be kept to a few individuals. And here are the references I used.